Today's webinar is titled From Silos to Collaboration, Linking Healthcare, Public Safety, and Behavioral Health. And this is part 2 of a 2-part series offered by the Gain Center. And today you'll be hearing from our speakers on aligning regional responses with identified needs and resources. The 4 presenters today are Dr. James Dunford, Officer John Leaning, Officer Brad Manser, and Officer Phil Tanis, and I will be introducing them in a couple of minutes. My name is Erica Ihara. I am Project Associate at SAMHSA's Gain Center and Policy Research Associates. And before we get started with the presentations, I have a couple of housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or in regards to the technology, we ask that you please type those questions into the Q&A pod, which should appear on the right of your screen, and we will be addressing as many of your questions to the presenters as time permits at the end of the webinar. And we also will be conducting a couple of polls throughout the event, and we appreciate your participation. So if you see a poll pop up on your screen, and if you would like to participate, we appreciate that. This webinar is being recorded and slides will be disseminated via the Gain's listserv following the webinar. We also will notify you when the webinar recording is posted to SAMHSA's YouTube channel. And a certificate of attendance will be available for download at the end of the event. However, please note that this is for personal use only and it is not for CEU credits. We have ASL interpretation for this event, and in order to view ASL interpretation, go to the layout in the upper right-hand corner of your screen. You select Hide Non-Video Participants and then change the layout view to full screen. Today we have 2 interpreters, and their names are Dave Gratzer and Marika Larson. There's also live captioning for this event, and to view live captioning, select the Accept button in the multimedia pod located in the lower right-hand corner of your WebEx screen. And the color contrast of the live caption pod can be changed as needed, and we do recommend high contrast style for best visibility. So next, I would like to introduce the agenda for today. So after I finish covering these housekeeping items, John Berg from SAMHSA will be giving some opening remarks, and then the presentations from our speakers will follow. So for now, I would like to turn this over to John Berg, who is Senior Public Health Advisor at the Center for Substance Abuse Treatment at SAMHSA, and he will provide some opening remarks. John?
Thank you so much, Erica, and welcome to everyone today for our webinar From Silos to Collaboration, Linking Healthcare, Public Safety, and Behavioral Health, Part 2, Aligning Regional Responses with Identified Needs. We appreciate you taking time today to participate in this informative follow-up to our webinar that we held on April 29th. SAMHSA is very pleased to provide this second webinar of a 2-part series on the importance of building community partnerships with criminal justice and behavioral health agencies. During the first webinar, we focused on San Diego's Serial Inebriate Program, or SIP program, exploring ways to build and support collaborations between key stakeholders to improve outcomes for those familiar faces in our criminal justice and behavioral health systems who experience mental and substance use disorders. Essential aspects of engaging partners, cultivating buy-in was presented, including practical considerations for building collaboration in both correctional and community-based settings. And if you missed this webinar, we will have it posted in the near future. As noted previously, treatment providers and criminal justice professionals tend to operate in silos, despite the fact that they often serve the same populations with behavioral health disorders. While over half of people in jails and prisons have substance use disorder, individuals who are identified in need of treatment and recovery supports are frequently unable to access those services when booked into or released from jail. This is often due to limited partnerships between criminal justice and behavioral health agencies, resulting in few opportunities to start or continue treatment. There is a critical need for cross-disciplinary collaboration to enable a recovery-oriented approach to support individuals with mental and substance use disorders who may be cycling in and out of local jails and hospital emergency departments. Today, part 2 of the series will address these types of issues and focus on planning considerations and practical steps for adapting cross-disciplinary partnership models to support individuals with mental and substance use disorders within diverse regional settings. You will have an opportunity to hear from a local Montana program about strategies for planning, scaling, and implementing behavioral health and criminal justice partnerships that are consistent with identified regional needs and resources such as population size, geographic size, staffing, training needs, technological supports, and funding. We are very pleased to have 4 presenters today. Welcome back to Dr. James Dunford and John Leaning, and welcome for the first time from Montana, proudly my state home, Officer Brad Mansour and Phil Tennis. Thank you so much for sharing your valuable knowledge and expertise with us today. And I'd also like to, at this time, just thank the Gain Center for their work in developing and facilitating today's webinar. At this time, I'll turn it back to you, Erica.
Thank you, John. So now I would like to introduce the speakers today to our audience. So we have Dr. James Dunford, who is Professor Emeritus of Emergency Medicine at the University of California, San Diego. And he is the medical director of McAllister Institute, where he oversees the Regional Sobering Center and also the care of patients who have substance use disorders. He has taught and practiced emergency medicine for many decades and served as the City of San Diego EMS director for 20 years. He co-founded the serial inebriate program that you'll be hearing about today, along with the San Diego Police Department, and also created the San Diego Information Exchange with 211 San Diego. Officer John Leaning, who is retired with the San Diego Police Department, where he worked for over 20 years, both as a field training officer in patrol and as a psychiatric emergency response team officer. He co-founded the serial inebriate program with Dr. Dunford and served as a liaison officer for the SIP program for many years. He has also assisted numerous communities across the country with developing SIP programs of their own in their own jurisdictions, and has done many trainings with police departments nationwide. And he currently is an investigator for the Office of the City Attorney, San Diego Neighborhood Justice and Collaborative Courts Unit. Officer Brad Mansour, who is a police officer with the Billings, Montana Police Department. He is a field training officer, a member of the community's crisis intervention team, and a member of the Billings Police Department Honor Guard. He is also an instructor for the department's naloxone and CPR AED programs, and he co-runs the Motivation Addiction Alternative Program, which you will be hearing about today. And Officer Phil Tennis, who is a police officer with the Billings, Montana Police Department. He is a field training officer, crisis intervention team instructor, critical incident stress management coordinator, and also a CPR AED instructor. And he co-runs the Motivation Addiction Alternative Program that you'll be hearing about today. So before I turn it over to our speakers, I wanted to just say a couple of words about who's out there in the audience today. So thank you to everybody who responded to our poll. Most of you are calling in today from urban locations, followed by rural and suburban locations. And we have a good mix of people in the audience from different areas. We have folks in public health, community-based organizations, academia, research, probation, parole, judiciary, law enforcement, corrections, and crisis services. So welcome everyone, and thank you so much for joining us today. And I am going to turn it over now to Dr. Jim Dunford to start the presentation. Thank you.
Thank you so much. Again, my name is Jim Dunford, and I'm really thrilled to be back to talk. And thanks again to SAMHSA and the Gain Center for this invitation to share some experiences. As you heard, you'll learn a little bit more about what we're doing here in San Diego. And then also about Billings, Montana, which is very exciting. So the first thing I just want to pay respect to is the fact that the programs that Officer Leaning and I will be talking about from San Diego really do result from over 20 years of collaboration between our city leadership as well as the county of San Diego. And that partnership is essential. To recap what we went over in the first workshop, very briefly, the first thing that we discussed was the high cost and the remarkably inferior outcomes, including enhanced death rate even, that result when individuals with very complex chronic medical and psychosocial problems receive disconnected care, which I think we can all recognize when we talk about siloed systems, everybody working collaboratively, but not really. We explained how the serial inebriate program, which started here in 2000, has integrated public safety, behavioral health, and the healthcare system to improve care for one population, and that was the chronically homeless individual who's living with alcohol use disorder. And the goal of our session, this session, and that'll be presented by Officers Manser and Tanis, will be to describe the Billings Police Department's Motivated Addiction Alternative Program. Then John and I are going to go back and discuss how here in San Diego over the last couple of years, our serial inebriate program has been applied to address a concern for individuals who are under the influence in public of substances other than alcohol. That program involves our sobering center, and so I did want to say a few words about the growing role of sobering centers can play in a community, and that will conclude our conversation before question and answer. Again, it's almost not even worth mentioning. I hope everybody understands this slide, that the individual in the middle belongs to all of us, and every stakeholder in the community who touches the life of an individual who is complicated, no doubt is intercepting with one of these elements of the public safety system, broadly defined, from judges and jails and prisons and probation and paramedics and fire, police and public defenders and prosecutors. We all touch the life of this individual, and really there's no solving the problem without everybody being engaged in a solution. This slide depicts a very important development of SAMHSA and the Gain Center in particular, and it's called the Sequential Intercept model. As you see, it's a standardized approach for communities to use to identify opportunities to divert individuals who are living with substance use disorder away from incarceration and to treatment. There are a lot of opportunities that present themselves for intervention along this spectrum. The model describes where you can and involve yourself at any one of these points, starting with Intercept 0 to the far left. The program incorporates community interventions that include crisis lines, proactive planning steps, including the identification of individuals who are at risk. And at each successive step, there are new opportunities for pre-arrest diversion, for court offers, and ultimately for prison and jail reentry. And I would point out that SAMHSA and the Gain Center provide opportunities for communities to come in and help them to conduct this form of analysis. Here in San Diego, we did it a few years ago. It was very successful. Our district attorney led that effort, and it led to some very important goals and objectives for our behavioral health programs here. One other thing that I'd like to point out is that the systems that we're trying to develop, the integrated approach of the leadership of all these entities, can be applied to many different settings. And in 2020, the Centers for Disease Control released this toolkit, which I would highly recommend, that provides a step-by-step approach for public health and safety leadership and other stakeholders to create the teams they need to address the epidemic of opioid death. This can be applied to just about any other situation you want, but it involves the component parts of pulling people together, and I highly recommend it. It's a downloadable item from CDC. I'm going to turn things over now to my colleagues from Billings, Montana.
All right. Well, thank you so much. We're very happy and honored to be here. Get the mouse to work. There we go. It's just a little bit about Billings. If you are not aware, it is the largest city in the state of Montana, and our population as of 2020 is 104,170. The square mileage of the city is 44.72 miles. It is the county seat of Yellowstone County, and we've been experiencing rapid growth, especially in the last 10 to 20 years. We're actually expected to double our population within the next 20 as well. We consider ourselves a service island, supporting much smaller communities, especially to the north and east and south. So northern Montana, western North and South Dakota, and then northern Wyoming as well. The closest city to the east of significance is Bismarck, North Dakota, which is 6 hours away. And then the closest city to the west is Bozeman, which is two and a half hours.
So a little history into our program. In 2014, Community Innovations was an oversight board created to showcase and facilitate projects successfully assisting vulnerable individuals to specifically address issues of chronic public intoxication and transiency in Billings, Montana. And from this, MAP was created. Before MAP, every organization was doing their own service work on an island, so to speak. Everyone was aware of other organizations, and most of the time there was a loose understanding of what services the other organizations provided. By bringing all the service organizations who worked with the same populations together, we were hoping to reduce duplication of work and at the same time provide multiple opportunities for individuals when they choose what treatment options. So for individuals, and when they choose what treatment option is best for them, everything seems to work better. So MAP, the Motivated Addiction Alternative Program, is a collaborative program intended to move people from addiction and cyclical negative behavior through a continuum of assistance and treatment designed to give people the hope and motivation needed for recovery and transformation. MAP utilizes both community service providers along with the municipal justice system to best aid individuals in entering and maintaining a drug and alcohol-free life. In 2017, overpopulation of our local jail, the Yellowstone County Detention Facility, caused MAP to become stagnant, and due to the lack of ability to incarcerate individuals for their quality of life violations, we saw an end to the program at that time.
So in 2014, when MAP first began, they needed to identify the individuals which MAP serves, and that's a very small subset of the population, currently at about 8% in 2020. And these individuals frequently interact with emergency services, medical facilities, and law enforcement. So in 2014, they tallied up the individuals, chronic high utilizers with 3 or more contacts within a year with law enforcement. And those individuals, through a community impact study, cost the city $8.5 million in unreimbursed services. Now in 2020, we redid that same study, but we increased the number of contacts to 15 or more a year. And we discovered there are 93 individuals listed with that category. And the way we were able to, with the 15 or more contacts, we focused on quality of life violations, or as the local court system would label them as street level crimes. So of our 93 individuals, which is 8% of our entire population in 2020, they were issued a total of 634 warnings, 547 citations. They were arrested 1,504 times. They had 633 active warrants as of 1/1 of 21. And they attributed for 5,601 law enforcement involvements over the year 2020. And so each arrest warrant served on an individual is counted as an individual arrest. Our highest individual was arrested for 88 warrants over the course of 2 jail remand incidents. So essentially he was taken to jail twice for a total of 88 warrants. Through the community impact study, St. Vincent Hospital stated that these 93, or 8% of our population, had a total of 863 hospital visits, mostly to the emergency department at St. Vincent, accruing roughly $2.6 million for care. The Billings Police Department stated that the 93 chronic high utilizers Cost the city of Billings $2.5 million in services ranging from officer interactions, written warnings, citations, and warrants. And this also includes police department records and court services. The Billings Clinic stated that in 2020, these 93 patients had a total of approximately 1,500 emergency department visits and accrued costs of $5.14 million. So our fire department and American Medical Response or ambulance service weren't able to provide their numbers at this time. However, total at this moment, we have $10.2 million worth of care. And a lot of these numbers, like I said, are underestimated due to the lack of data and the lack of data that we are able to obtain through our reporting systems. And even for Officer Manser and I, our numbers are underreported because we only technically inform dispatch of about 25% of our interactions. Most of our interactions with our chronic high utilizers is waking them up from doorways, moving them along from parking lots or business entrances where they're not supposed to be. And we don't run those individuals through our dispatch because it ties up the radio and we're already aware of their current warrant statuses.
And so one quick correction from the last slide, our 93 chronic high utilizers are actually 0.08% of our population, resulting in a large amount of service use. So we were able to bring MAP back in December of 2020. From 2017 to the end of 2020, the MAP program was stagnant. And in December of 2020, the Yellowstone County Sheriff's Office contacted the Billings Police Department and offered to provide 10 special jail beds, 5 for men, 5 for women, in order to re-implement the MAP program. From this, MAP was reorganized and revamped to provide more options for individuals for treatment. The new options included inpatient treatment, which through a sentencing option allowed individuals to enter into the MAP through a guilty plea and their sentence to be furloughed in order to enter a residential treatment program at a local provider, Rimrock Foundation, or the Montana Chemical Dependency Center. Originally, MAP was an intensive outpatient-based program with one option for group. Now, MAP has coordinated and communicated with multiple IOP programs to provide the client with the choice in what group would best suit their needs culturally, emotionally, and mentally. Also, an important addition was made to MAP. The Rimrock Foundation provided 2 peer support specialists to assist our resource outreach coordinator with outreach. These peer support specialists are able to bring real life experience in order to better relate to clients that MAP serves. They assist our clients by leading group therapy sessions, entering and signing up for stable housing, and obtaining Medicaid health insurance. While we include jail stays in our program, we try to limit jail time and utilize inpatient and intensive outpatient as alternatives. This program is mostly based around jail diversion. Because of a large Native American representation in crimes committed, culturally sensitive and appropriate organizations are an essential part of the program. Within our designated patrol area in downtown Billings, anyone encountered committing an observed violation is either issued a citation, warning, or notice to appear into court. With every contact, individuals are given resources and resource information for their given circumstances. People are contacted through bike patrol, walking the beat, or routine patrol car travel. Known problem areas are the primary focus of patrol time spent, and enforcement activity is not race, gender, sexual orientation, or economic status related. We do not actively seek individuals, but our enforcement activity is based on quality of life violations. If we did not track race, we could not adequately provide culturally appropriate treatment options, and a state law in Montana requires race tracking on all police encounters involving enforcement.
So there are 2 obvious portions of MAP. There's the criminal justice side and the treatment side. Just some of the partners that we have involved is first and foremost the Billings Police Department with Officer Manser and I. We're the downtown resource officers working out of the Downtown Billings Alliance office. And MAP was originally created by officers working out of this program. We work in a special tax district where an increased tax pays for our salaries. And we respond mainly to the needs of the businesses in that tax district. And most commonly as of late, the biggest issue of concern are people experiencing homelessness. The Billings City Attorney's Office handles all of our charging, sentencing recommendations, revocation, or similar warrant procedures, and they've been very crucial to ensuring MAP's legality. The Billings Municipal Court is aware of the MAP program and as a sentencing option for our defendants, and the Public Defender's Office can make MAP recommendations to defendant clients. MAP is only a sentencing option if the defendant pleads guilty to charges stemming from quality of life violations. The Yellowstone County Detention Facility is the only rural jail available to the city of Billings, and in 2017, when the jail became full and unable to take MAP offenders, MAP came to a standstill. And without the ability to incarcerate individuals for non-compliance, MAP saw a lack of cooperation from sentenced defendants, and with no ability to incarcerate those individuals out of court compliance, the program was placed on pause. So every partner needs to commit to the successful operation of the program, and if one part fails, the whole program fails. This program really does rely on each partner providing their expertise in their fields, and we're not asking the police department to be experts on social services, just as we're not asking the social services to be experts on the law. We're just simply asking for each partner to do what they do best at, and we're all just one piece of the puzzle. So just as there's the criminal justice side, there's also the treatment providers as well. The Downtown Billings Alliance is composed of 4 separate nonprofits that work independently and collectively on behalf of Downtown Billings. The Community Crisis Center is a drop-in crisis center, which has approximately 18 beds for shelter care. They also provide daily group, case management, and counseling, among other services. Billings Urban Indian Health and Wellness Center serves Native American populations and all other members of the communities throughout the region looking for holistic, culturally competent healthcare. They accept all patients with or without health insurance and connect them with necessary resources in and around the Billings area. And they have been very crucial, as Billings is very close to 2 large Native American reservations, the Crow Reservation and then the Northern Cheyenne Reservation as well. The Rimrock Foundation is the largest treatment center in the region, providing rehab services for adults with substance use and co-occurring disorders. Rimrock views addiction as a whole person illness affecting individuals' emotional, physical, spiritual, and social well-being. Rimrock has agreed to provide a quick entry treatment upon sentencing with MAP. They place the individuals on a high priority list, and that's for Medicaid beds. MCDC provides intensive inpatient treatment that cares for the disease of addiction, including withdrawal management for substance use disorders and treatment for co-occurring mental health disease. And then St. Vincent de Paul is a local nonprofit that serves breakfast and lunch daily. And they've also been providing space for other organizations to host outpatient groups. They provide payees and case managers as well for our clients. And lastly, the Mental Health Center is an organization dedicated to the establishment, development, and maintenance of high-quality mental health and chemical dependency care in South Central Montana. And they currently hold a contract with the local jail and are able to provide mental health services there.
So how MAP works. Before the MAP program in 2014, a high-level enforcement was performed on any violation of crime in the downtown area. High numbers of citations and arrests were made. And as we've known from the beginning, this is not a problem that a city can just traditionally police its way out of. Without other options, this enforcement activity was the only tool the police department had, and it was not effective. In 2014, with the first community impact study, it proved what we knew, that it was more than just a law enforcement solution. So we have 2 tracks. The first track is the volunteering into MAP track. And by volunteering, an individual is required to complete 90 days of recommended treatment. A chemical dependency evaluation is done, and all treatment follows those recommendations. If and when 90 days are completed, the individual and officers will go in front of the judge to show program completion. The judge will dismiss all quality of life violations and warrants, giving the individual a clean slate. The last thing we want is for an individual to start on the right path and have to worry about legal and financial costs of prior actions. The second path is our sentencing through courts path. That starts with an individual being arrested for numerous quality of life warrants or frequent recent violations. With that arrest, they can be referred to MAP as a sentencing option. If they plead guilty and are sentenced to MAP, a defendant becomes a client, they will sit 2 weeks in our local jail, 2 weeks or less. In that time, they will receive their chemical dependency evaluation. They will go through Medicaid sign if they need to. They will be exposed to crime for life. And those 2 weeks will also be used as a detox period. Once 2 weeks have passed or treatment is open, they will be sent to an inpatient 30 days. In Montana, 30 days is the maximum that Medicaid will pay for inpatient treatment. After 30-day completion, sober living, safe living will be found for the individual. They will spend 30 days of intensive outpatient of their choice. And after 90 days of being in the program, a 90-day status hearing will be set with the courts. And if in compliance, that will be sentence completion at that point.
Okay, so while developing the program, we immediately noticed the importance of a memorandum of understanding with all partners involved. And that's essentially a written promise defining what an organization is willing to provide for a program like MAP. In the past, we've been given promises by certain service providers or law enforcement agencies, and then they have not followed through when we've needed their services. And so the MOU has the organization take a serious look at the problems facing our community by their involvement or lack of involvement and what they can truly provide. The MAP program found partners in the community who are willing to work with the same populations of individuals that we were. And because organizations have different missions and goals, clearly defined contributions, which they can guarantee to the program, is very important. These MOUs provide the ability for groups to talk about patients or clients as they maneuver through the program. Because the program involves a court-ordered component, consistent communication is very essential. We are working on implementing MOUs with all of our organizations we work with. Right now, we have MOUs with Rimrock Foundation, the Community Crisis Center, St. Vincent de Paul, and then our court system. And we're currently working on MOUs with Healthcare for the Homeless, Yellowstone County Detention Facility, and Billings Urban Indian. And so, for example, if a organization can guarantee 4 beds in an 18-bed community crisis center, this is huge in helping individual come out of their inpatient treatment to intensive outpatient, because a stable place to stay is important. We find that if somebody is worrying about where their next meal is coming from or where they're going to sleep for the night, they're less able to focus on their treatment.
Where are we today? At the beginning of April 2021, the jail had concerns as to the budgetary side of MAP, causing a freeze on the incarceration track of MAP. As stated before, MOUs play a significant role in MAP as they hold both parties accountable in holding up their side of the bargain. A mistake that was made early on when the Billings Police Department was presented with the YCDF beds was an MOU was never written and signed by both parties, causing a freeze ultimately occur. An early MOU would have prevented this freeze, as their concerns would have been addressed sooner. Since then, talks with administrations from both the PD and the county have resulted in a path for an MOU and the resuming of services being provided at the jail. As of the beginning of April, 2 of the first women to enter the MAP program have completed their first 30 days of inpatient treatment. One woman went into a safe living environment with family to begin outpatient treatment. The other woman walked out of treatment and quickly re-entered into her cyclical negative behavior, being seen entering a bar. Revocation warrant was filed for her. So, some commonly asked questions. How does MAP actually help the city? The goal of MAP is to reduce contacts by each high utilizer by 50%. That is 2,350 less law enforcement calls or 1,055 less ER visits in a year, saving millions to the taxpayer. And due to the cost, each organization and ultimately the taxpayer MAP, by reducing services of those 93, frees up law enforcement, fire department, American Medical Response, and our medical providers to handle higher priority calls and medical services. How does MAP benefit the individual? MAP benefits the individual in multiple ways. However, the most prevalent is that it provides a way into recovery for individuals who would not otherwise have internal motivation to do it themselves. Most program sentences are complete either through the guilty plea or going voluntarily, and this allows individuals to focus on paying for housing, obtaining safe jobs, and not having to worry about a plethora of court fees and fines. How long is the treatment program? Due to Medicaid funded health insurance, which an overwhelming number of our clients have or are eligible to obtain, inpatient treatment is more often than not limited to 30 days. Post-inpatient treatment, we have individuals complete a 30-day intensive outpatient program. This, along with the up to 2-week detox period while incarcerated, or 7-day while in treatment facility, will total up to approximately 64 days in length. Is the counseling program culturally centered? What we pride ourselves on, besides service provider communication, is the client's ability to choose what type of treatment program works best for them. Due to our great communication with service providers, there are multiple options for IOP. We have aligned groups with MAP that are religious-based, non-religious-based, and culturally centered to set up our clients for the most successful treatment program for them.
So what offenses fall under MAP? So MAP is focused on quality of life violations where the only victim of the crime is the perpetrator themselves. And these offenses include open container in public, public urination or defecation, criminal trespass to property or vehicles, and then misdemeanor theft. Is there consistency in the sentencing for these offenses? And consistency is key to this program. It allows but does not force individuals into treatment by presenting the obvious option of treatment. And then while you went to Billings Municipal Court and having the cooperation and support of our city judges, who are typically doing the sentencing for up to 6 months, but always maintain the discretion to change the sentencing as they see appropriate, allows the client to see that they can spend 2 weeks in jail and go to treatment instead of spending up to 6 months in jail. And are we forcing people into treatment? And as stated above, we are never forcing individuals into treatment. Each client always has the choice of pleading not guilty and going to trial, guilty and completing their sentence in custody, or pleading guilty to their charges and entering MAP. Our city attorney's office has been dismissing a majority of the individual's charges, such as 29 out of 30 warrants, if they choose to plead guilty and enter MAP. And are we criminalizing addiction or homelessness? And we are not doing that. However, we are enforcing law violations commonly seen in these groups. And that being said, each of the quality of life violations can and are being violated by individuals who are not homeless. Also, a vast majority of our 93 chronic high utilizers have homes with friends or family, just not in Billings typically, that they can go and stay with. But more often than not, they choose to sleep on the street just to aid their addiction.
So in that first segment, I think it's just fantastic to hear how Billings Police Department used a model that was similar to what we had adopted in San Diego, but obviously tailored it to the community. And I think that's the point of our whole conversation today, is any community can do what we're talking about. And we know that everybody has the problem. We had another problem I think most communities would recognize too, and that is that, we're not just dealing with alcohol-related use disorders in our communities these days. There are a whole host of other issues that demand this kind of collaborative approach. And in 2019, we started seeing, for a variety of reasons in San Diego, open drug use really become much more prevalent. A lot more encounters by law enforcement with individuals under the influence of substances other than alcohol. So Officer Leaning and I would like to talk a little bit now about a program that we are a part of. It was definitely provoked by methamphetamine overdose deaths, which were on the rise, as well as our own version of fentanyl and other opioid use disorders that came to our shores. And we started noticing a rising death rate due to methamphetamine. I just saw the numbers recently again for 2020, and they're almost logarithmic in terms of meth and fentanyl and opioids. And this happened coincident with a number of changes that occurred in California law that pertain to the possession and sale, not only of methamphetamine as a controlled drug, but essentially all controlled substances. Many previous felonies became misdemeanors. Many misdemeanors could be addressed by diversionary proceedings. We faced our own prison and jail overpopulation, and there was a move afoot to have to move a lot of people from incarceration to the streets. But coincident with that, there is still the problem of insufficient treatment. And so what do you do when you're in that situation? And so Officer Leaning John is going to discuss a program called Pleads that we actually developed collaboratively.
Well, first, I'd like to thank the Billings Police Department for their willingness to try something different. Agencies that are often viewed as the prosecution or the hammer side of the criminal justice system are the same agencies that start these diversion programs. In our last webinar, we talked about the serial inebriate program and the success we had in diverting individuals who suffered from alcohol addiction from incarceration to the appropriate services. So we got to thinking, why not expand that opportunity to all individuals who are suffering from all or most substance addictions? So we did. Basically, about 2 years ago, we started our Pleads program, prosecution and law enforcement assisted diversion services. Because if you know the police department, we're really all about acronyms. But basically what we're trying to do is we're trying to offer treatment and services in lieu of that incarceration. Pleads is very similar to our serial inebriate program, diverting individuals who are under the influence of a controlled substance from the street and out of our jails to our sobering center. We're going to talk a little bit more about our sobering center, but Jim, is there anything you would want to add to this part of it?
No, actually, just for those that didn't see our program, our first presentation, the serial inebriate program relies upon an agreed upon definition of someone who's chronic, which is 5 visits, 5 transports by law enforcement to the sobering center within 30 days. Makes you eligible for the SIP program. In this situation, it's 3 visits to the sobering center for being under the influence within 90 days. But the sobering center is basically the way station where law enforcement will bring you initially when you're under the influence of whatever we're talking about here.
So a lot of what you heard Billings talking about with MAP, it's very similar to the serial inebriate program and Pleads. This is really about getting out of our silos and working together. We had already established a core partnership through our serial inebriate program, and we've been able to maintain those relationships and include new partners. So
one thing that John and I wanted to mention as well is that our program is adapted from the law enforcement assisted diversion program, which was first described in 2011 in Seattle. That's that program which did seek to move individuals from low-level offenses, low-level drug and prostitution offenses to social and legal services instead of being prosecuted and incarcerated. And actually a study in 2017 had shown, in comparison with a group of individuals who did not go through the program, a 60% lower odds of arrest in the first 6 months, and over 2 years, 58% lower odds of arrest. So there's evidence to support this approach, and San Diego paid attention to that, as many other communities are aware of similar types of diversion strategies.
So again, these are some of our partnerships. Partnerships are the main key to any of these programs. You have to maintain them. Everybody's an equal partner, as Billings has mentioned. And, we're all equal. You have to meet, you have to discuss, and keep that dialogue going. So how does the Pleads program work? Basically, the police department will contact an individual who's under the influence of a controlled substance. Instead of transporting that individual to jail, we're going to take them to our sobering center. The sobering center staff will conduct a brief interview with the client for appropriate placement. As I mentioned before, we're going to talk a little bit more about the sobering center next. and what services they provide. But basically, a warm handoff of the client is complete, and the officers will then leave the sobering center.
These two pictures show the current sobering center in San Diego. The funding for this is jointly paid for by the County Behavioral Health and the City of San Diego. It is a very simple facility. It's only for law enforcement. We do not accept walk-ins at this time or transfers from hospital, although other programs in other communities do. You can see that the layout is very simple. Individuals are transported by law enforcement and are asked to spend 4 hours on a mat. We've got a dividing wall that separates women from men, and we'll have as many as 60 individuals in here on a night, particularly if there's a big game or something going on and there's a lot of reveling. So our program actually does, and I'll show you that in a second, cater not to primarily homeless chronic users of the system, but actually individuals who, for whatever reason, can't get home safely and need a safe place to sober for a period of hours. The front door and the bright door there up in the front comes from the parking lot. Actually, during COVID, that's where all the screening occurs. We have an interview outside while the individual typically is still in the police car with a nurse or a counselor who goes out and just talks with the client, make sure that everybody agrees that they're a good candidate for the program. You can imagine certain kind of violent behavior or other things is not going to be conducive. We do not actually have security in our facility. We provide a rapid turnaround for the law enforcement personnel who use it. So down in the lower left, you see our registration book. Officer fills out pretty minimal set of information about the individual, what part of the police department, central division or whatever did the individual come from, age, and a few other notations. And as long as the individual is kind of willing to stay, then great. Otherwise, they'll be taken to jail or to the hospital if the medical staff feels that there's a medical issue that needs to be addressed before they can come in.
Yeah, we talked a little bit about our partnerships. Key partnerships, this is one of them. The McAllister Institute has been a great partner to work with, having that relationship with law enforcement. So we, myself and Dave McGowan, who's an officer who is running our serial inebriate program and diversion services, will attend lineups and talk to the officers about who's appropriate to go to our sobering center. We're not going to take an individual who's violent. If they're in medical distress, excited delirium, issues like that we will not bring to the sobering center. Also, if you're at a ball game in San Diego, if you're at an event and say the San Diego ball team is losing, big surprise, that you may have too much to drink. And, your individuals who had a little too much to drink will go here as well. So it's all sorts of people from the population that will be using this facility.
And we have over, you'll look across the spectrum of sobering centers in the United States that are being built, and there are sort of entry-level places that will accommodate people just for a 4-hour stay, and then there's much more expansive care that can be rendered. In our situation, we provide people with clean clothes. We have a place where they can store their belongings, and we have a restroom. We have a washer and a dryer, and some basic amenities, some snacks that people can have. But they're really expected to quietly rest on the mat. And of course, that becomes a challenge we get into when it comes to methamphetamine, because there's a lot more skill involved in terms of the management of people who are more likely to be up and about. So let's just look at the first population that I was referring to. For many years, we've dealt primarily with people who are under the influence of alcohol. And this is a breakdown of what that looked like. This is from May 1 until June of 2020. Individuals who came in under the charge of 647F, which is drunk in public in San Diego. You can see the majority of people are younger, and mostly there's the race and ethnicity distribution to the right-hand side. I'll contrast, well, let's go next to self-reported housing. This population, as I've mentioned, is not generally homeless. They just can't make their way home. And so the PD bring them to us to spend 4 hours until a family member or somebody can come and pick them up. Employment status, you can see 40% reported that they were employed. I'll contrast that with the next group, the Pleads population, in a minute. When we did decide that we wanted to tackle other issues, and thereby I'm saying also opiates, benzos, spice, but primarily meth, it was felt important that we have some level of healthcare provider, meaning registered nurse, during the daytime hours when the police were bringing them in. I can tell you we haven't had a medical emergency in 2 years. It's interesting. So there are other models that use EMTs and paramedics and others that don't use any healthcare model. I think the story's out on that, if depending on your system, exactly what level of healthcare. We have no pharmacy here. We don't provide any medications like that. We don't even have medications for scabies, to be perfectly honest. But what we did do was to augment our team. We have an SUD counselor and we have a health navigator, because we wanted to take it to that next level where we could try to bring people to the resources that they need, not just 4 hours and some explanation of what opportunities might exist in the community. We wanted to try to link people up. And to that, we had to go out again to our partners in the community, the Sobering Services Center, not only in collaboration with our homeless outreach team and the SIP team from the police, but getting to know everybody in the community who provided withdrawal management. We do ourselves. McAllister has our own beds, a limited number, but also the shelters, particularly during COVID. We did a lot of work to try to get people to just out of the rain. The homeless outreach workers, and there are many different kinds in San Diego, who are also communicating with us, and we trying to help them find beds. Obviously, mental health resources, which is really critical because so many of our patients are co-occurring. A lot of people off their meds. And so it's not unusual for us to keep people much longer than 4 hours. We now are up to 24 hours in keeping people if we see bright light at the end of the tunnel. Medically assisted treatment, MAT. We do not provide it, but in California, there are a number of programs that are called bridge programs, and the hospitals are actually in partnership over 60 in California to begin buprenorphine and the medically assisted treatment that our clients will need if they're on their way to a withdrawal management bed. Same thing for alcohol. People get Librium and they'll get all the other medicines, and we will link them up with psychiatric medications. So if we know somebody's bipolar disorder, they've been off their meds for a month, it's obviously very important to arrive at a withdrawal management bed with all your medicines ready to go, and your diabetes too. Here's a view of the census, the monthly census before and throughout the pandemic, and you can see that the number of clients who were brought in for alcohol, 647F, the red columns, declined, but the Pleads program grew and then declined a little bit because also our jails were really impacted and everything was impacted in the community. And overall, the fortunate thing is that we still continue to see a goodly number of Pleads clients coming despite the pandemic. We had to reduce our capability, of course, in the facility by half just for social distancing purposes. Much the same way the rest of the community had to decrease the number of available beds because we couldn't put 4 people in a room anymore. We could only put 2 because of the pandemic. Now, if you just think back about the first population that comes to the Sobering Center, this is the group that fall under the category of Pleads. More males, age again, still young for the most part, men, but a much higher percentage that are expressing homelessness. So that's the real population that we see. Unfortunately, San Diego is the 4th highest homeless population in the United States at the moment. So this is a really important issue for us to try to decompress all aspects of the community, and particularly downtown. So here's what our clients identified as their drug of choice. Once again, I've mentioned meth, but 80% of our clients meth. Of course, more than one person is taking a combination of these drugs. Yes, we obviously have naloxone on site. Yes, we have a defibrillator on site. It just doesn't come up, interestingly enough, that these people that are selected by our law enforcement and our medical staff out in the driveway, that we have not encountered the kinds of emergencies that you might anticipate. And I think that's a statement to the fact that substance use treatment providers recognize who's in trouble and who isn't. This is some optimistic data that we have. It shows of 1,000 individuals who came in, 1,005 intakes between that time frame, how many actually stayed 4 hours, how many police actually said were not suitable. So incidentally, law enforcement brings all these individuals to the sobering center. It counts as a first visit. So remember, 3 visits in 90 days actually can trigger a legal response by the city attorney to prosecute for these crimes. So they're brought, the police feel, no, they're not a candidate, or it may be that the staff refused for whatever reason. We always give our medical staff the prerogative to say, no, that wound needs to be dressed, or this fella looks like he may have, some significant withdrawal features that really need the attention of one of the ERs nearby. But if we take that 664 people who stayed 4 hours, we then ask of how many of those would like to enter into some form of treatment, and 24% of people actually were willing to do that. So that gives you a gauge of the, if you say willingness of individuals, even freshly from, a period of intoxication or inebriation in the field from drugs like meth, that would like to accept treatment. And that gives us great hope that as we expand our capacity in the community to handle more patients with more withdrawal management beds, that we're really going to be able to make an impact downtown and everywhere across the community. So I think that there's hope here. And we all know that. I mean, we're always looking for that opportunity when somebody's willing to say, yes, I want to change course. And just the mere transport to the sobering center a lot of times provides that stimulus to people to start thinking twice. They've had 4 hours, if not 8 sometimes, to talk to our staff, and they really start to get a little bit better sense of, of their own predicament and how willing other people are to help. Now, just to kind of round up before we get to question and answers, I would like to just say that for those of you that are interested in sobering centers, there is a wonderful collaborative that's now been formed over the last several years called the National Sobering Collaborative. We actually held a national conference in Washington, D.C. 2 years ago, and had many cities who were interested in creating these of one form or another. And they have a monthly webinar. You're able to go on and you can discuss what your plans might be. I'm talking about towns big and small. It's interesting. Washington, D.C. is planning to develop a program that they have not had. And they came out to visit us. Other well-established programs like Los Angeles and San Francisco and Houston has a wonderful program, San Antonio. All around the United States, people are looking at this. Baltimore, what should we have in our sobering matrix? Should we offer intermittent medical care? Should we have nurse practitioners? And sure enough, you'll see those kinds of systems if they're right for the particular setting. Kansas City, another really good young program. So I would definitely check that out. Now, one of the things that comes up is, how am I going to pay for this thing? And so as my last slide, I would just say, I think that there's real interest in developing funding solutions for these over the long haul. This is a list of services that are being proposed in California for 2024 for our Medi-Cal program. Now, these are programs that are potentially available if the insurance companies, the managed care organizations who contract with our state to provide care for their clients, these are the types of services that the managed care organizations may be allowed to fund as part of the their participation in California's Medi-Cal system going forward. And so obviously I highlighted that sobering centers will be an opportunity for us to actually see different levels of funding coming in as people understand that these are part of the continuum of care for substance use disorder. You got to start someplace. And we're talking really now about individuals that are highly vulnerable, typically Medi-Cal population in our community, and very often homeless. So we're not catering to a population of well-insured people, but rather the vulnerable who, by the way, we've already amplified many times, are the most impactful on the community, from police, fire, behavioral health, and all other points of view. So that's another interesting caveat I'd like to mention. And in conclusion, we do have a list of references, and I basically just want to say to everybody who's with us today here, I mean, at Billings, you guys have any closing comments, or John?
I'd just like to say that, I hope that the last two webinars have been informative and that you got something out of them. But if nothing at all, I just hope that there's a willingness, like Billings Police Department did, to try something different. If you can't fail if you don't, if you fail, you're always going to go back and do what you were doing before. But, the partnerships and the collaboration are the most important thing. Get out of the silos, work together, keep that dialogue going, and be amazed in the things that we can do.
States like Montana are different than California, and we don't have a public intoxication law. Our bodies are not a container. So we had to work around that and adapt our program in order to fit it legally. And we don't have sobering centers either. So it's all about working through the problem and working with your community members and getting a good, solid dialogue together in order to problem solve. So.
All right. Well, thank you, everyone. Dr. Dunford, Officer Leaning, Officer Tanis, Officer Manser. Thank you for sharing information about your programs today and your wealth of collective experience. We now have a couple of minutes to cover some questions from the audience, and we have quite a few questions coming in. And I'd like to encourage folks in the audience right now to please continue to type in your questions into the Q&A pod, and we will continue to just move through these questions and cover as many as possible before we end today in about 25 minutes. So I'll start with, so this is a general question. Why don't I start with San Diego, and then I'll ask Montana as well. So if a community wants to start a similar program, who are some of the key members that they should be thinking about including right from the beginning? And so key members, stakeholders, agencies. I know you've covered some of that a little bit in the in your presentations, but just starting with San Diego, if you could just review that again, that would be great. Thank you.
Yeah, obviously you want the key players that are your law enforcement, your prosecution, your public defender, your hospitals, but also you have to pull in the politicians. There's obviously a political component to all this. And the most important, I think one of the most important players is your community, your business owners, your residents, the people that are out there every day. Have them be involved in the conversation from the get-go, and all, definitely the clients themselves. We've learned more about our programs through talking to our clients. They tell you what they want, what they need. They can tell you, what they are getting an abundance of and what they don't continually need. But really having that dialogue with everybody is important. And when you have those meetings, have that first meeting, expect people to bring concerns and expect the walls to kind of be there, and acknowledge that and address it, and then get the dialogue going. And then we always say, meet every month as you're starting the program out. Anybody that has an issue, let's work through it. If you can't work through it, then we're done. But you can always work through the problem if you keep that dialogue going.
I would just add that, yeah, finding champions is really important in any of these kinds of things. There are always police officers that want to address this issue. I've never gone to a city that I didn't find that there were individuals who really wanted to participate. I was the medical director of the city of San Diego, and I saw it from the fire department point of view. If you can find a champion on the healthcare side, if you have that ambulance medical director, if you have a city EMS, if you're a bigger city, they feel the pain as much, if not more, than the police department do. And so you have a ready ally in any other response, part of the public safety response system. You just have to find that one person. It could be a battalion chief, it could be a captain, it could be a paramedic in the street who's just been on the same guy 20 times in the last month. Somebody out there who really feels like the system's broken.
So for Billings, with our population size, all of our services are centralized in our downtown corridor. And besides or adding to everything that San Diego has said as a player to bring in, we found that we call it a resource outreach coordinator, and our resource outreach coordinator is Cody Christensen-Litton, and he is the one employee or tool or individual to make or break a program. Cody is who goes between all of the service providers who may or may not talk well. They've been competing for the same funding for years. They have the same clients, and he is the bring everything together, the making the meetings. He runs we call it community innovations, but that's our board that runs MAP, that's the leaders of all of the service organizations, and he's the liaison between everybody. And so without that person sitting at the meeting, someone who's dedicated full-time to the program, these aren't things that you can let someone do in their downtime. I don't know of many law enforcement agencies specifically that have a lot of downtime for any of their officers to just work at something here and there. And so having a resource coordinator, a manager, someone to really take the ball and run with it, get meetings going, hold people accountable, get in front of city council, get county commissioners on board. In Montana, we have county commissioners, make meetings with the jail, the sheriff. Everyone's very busy, but having someone that can get you on the schedule. And so that's what I would say is important.
Thank you. That's very helpful. The next question I'm gonna ask of the Billings team. So because you have been in the process of starting up the program again in 2020. So one audience member wanted to know if you could talk about some of the big barriers that you experienced when starting the program or restarting it. And maybe if you're comfortable sharing what barriers you're currently encountering with implementation.
Right. So in 2014, they were given this program with no jail restrictions. They could just bring any individual at any time. And so that started off very nicely. Now at the end of 2020 in December, the jail came to us and the sheriff's office came to the police department and said, here are these 10 beds for 5 men and 5 women, because we're getting so much pressure from the community and the commissioners. And so I was just starting in my position and Brad had been in it for a year. And so we were like, oh boy, here we go. And so we had to work completely backwards in starting the program back up. And so that was a big problem, is we were really trying to catch up, and we're just wanting to keep those jail beds for this program. So we were just arresting people on outstanding warrants when in reality, they're not going to be the best candidates for that program because they have no interest in maintaining a life of sobriety. And so that was an obstacle. And then currently, a lot of the problem is education. And you're going to have individuals and politicians and members of different organizations that want to be involved and want to help out. However, they're not quite educated enough. So spending that time to educate those individuals and have them all on board, such as the public defender's office and the sheriff's office, and then all the entities involved.
So for Billings, we find that there is nobody to get people to and from. So a barrier is our St. Vincent de Paul is a open during the day center where people can go see a case manager. They have different health organizations go for clinics, different things. They're several miles away from other providers that someone might have appointments for. We don't have a service to get people to and from. And so that's a barrier as well that we are working through with our resource coordinator and having a vehicle, an actual vehicle to move people to and from appointments. It's very easy to get sidetracked when you have to walk 3 miles to find the next provider that you're supposed to meet with that day. And so that's one of the barriers that we have actually overcome through having a vehicle and having a person that can spend time to get people to and from locations.
Great, thank you. So the next question is around data integration, and I'm just going to open this up to whoever on the panel would like to speak to this. So folks would like to know just what are some strategies for making data integration possible, that the kind of data integration that is necessary to enable these collaborations across partners and agencies. So just any general comments or tips and strategies that you would like to share, and I'll just open that up to whoever would like to respond.
So this is Brad and Billings. One big thing is, what is the goal of the program? What are you going to track, and how is it important to the continuation of the program? And so for us, we wanted to find who were the tip top of our high utilizers. We had picked a very specific number, 15 contacts with law enforcement in a year. From there, we took that to the hospitals and everybody else, and they ended up having the same people for the same high rates. And so you have to pick something that's not arbitrary. Pick a number, pick a population subset, pick violations you're looking at, and it doesn't have to start at the police department. The same study could have been done starting at the hospitals, and we would have came up with the same people, given our size of our community. It's the same 93 in our case, no matter how you slice it. So it's very important to what's your goal, what are you looking at, and how can that data help you? And so we found it as helpful to show what impact can our program have. And so that's how we got our data.
In San Diego, we have the same issues that, unfortunately, I think all the way up to the federal level, there are still things that get in the way sometimes of care coordination for individuals, particularly when they have substance use disorders and co-occurring mental health issues. So we're always, protective of that, but at the same time, obviously realize that these are the folks who need the assistance the most. And so for our sobering center is a gateway that now actually has an access to the Housing Management Information System of the United States. So HMIS, right, which HUD requires data in order to be able to get the federal funding for housing. We actually have access to HMIS in our sobering center. We have view-only capacity to look at a program that we created called the Community Information Exchange. We don't share information into it, but we can see individuals to identify who else is trying to care coordinate this individual. And for example, housing, food, all those kinds of participants that are in the program, we can actually see that. So we have a little bit better of an idea. We're working strenuously to try to open that up even more through consented agreements for individuals to share data, because that is the ultimate goal here, is to try to be able to share information and collect good outcome data that that we can actually show to demonstrate that we're really making a difference. So that's it. I mean, most substance use disorder programs like ours are still on paper. That's the hard fact. We are moving to an electronic health record this year, but we were not part of any of the original Obama monies that went to physicians and hospitals and other groups like that. Substance use disorder did not get those funds initially years ago. So as that comes, I have every reason to believe that we'll be able to develop more and important tools because we see a lot of people. A sobering center, for example, is a hotspot. A substance treatment program is a hotspot. We see the individuals who should qualify for better coverage because they have so many of the high risk issues that the insurance companies are even paid and incentivized to wrap around services around. But so many of these people are difficult to find. So I think the federal government and the states are beginning to recognize that we are actually a valuable but not really well recognized source of identifying those individuals who have the greatest need. So hopefully that'll work out in the next year or two. Does that help at all?
Very helpful. Yes, thank you. So we've got a couple of questions that are specific to the programs covered, but there's one more general question that I'd like to make sure we get to before we end. So again, this is for anyone on the panel who would like to respond. We have a question from an audience member about asking about what are ways that you're working to reduce racial disparities and promote racial equity through the models that you talked about today. And so again, anyone on the panel who would like to respond, the floor is yours.
So as we saw on our slide, demographics in Billings, 73% of high utilizers in Billings were Native American. Because of that, we really worked to include any and every provider that had culturally sensitive or culturally specific treatment approaches. And there are several in our community, and we just made a point, we have to have them, and they want to work with us as well. And it just has to be a community effort, but it makes individuals, it can help someone overcome something and that I may not be able to help them with. We have, through our mental health center, we had contracted 10 hours a week before COVID with a licensed addictions counselor who was a tribal member of one of the local tribes. And just him going around with an officer doing outreach had positive effects. People still ask for him specifically when we're out and about. And so very small things can have big impacts because a lot of places don't make that one small step. And as soon as the things are opened up again, we hope to resume that relationship.
Thank you for that. Anyone else want to respond before we move to the next question? Okay, so this is for San Diego. We had quite a few questions specific to the sobering center. So I'll just try to run through a couple of these. So one was a question about drug screening at the Sobering Services Center. And Jim, I think this was in response to some of the statistics you shared about the types of drugs that people were using when they were using your services. And so folks want to know, do you do a drug screen upon entering the Sobering Service Center? Or how do you otherwise learn what substances a person may be using?
We do not do any drug screening, drug testing. It's a self-reported, preferred drug of choice. That's what we just ask people, what do you use? And people are usually quite open and honest about it.
Thank you. And then the, sorry, I lost my place here. So another question about the Sobering Services Center was, is this only for public intoxication, or are there other scenarios where somebody could be summoned to have to go there?
No, really. This was set up in San Diego way back in 1984 as a means for law enforcement to be able to divert somebody away from custody who was a nonviolent individual who could not otherwise be able to get home safely. And it doesn't, as I might have mentioned, we have discussed opportunities to divert people, for example, from emergency departments, which is a good idea and is used very successfully in other programs. For example, people who are, you have to be able to walk into our program. So if you're You know, if you're unconscious drunk, you're going to the emergency department. Emergency departments, having been an ER doc for 35 years, I can tell you, I took care of a lot of people who sobered in the hallways for hours, and then where would I send them next? I would have loved to have been able to send them to a sobering center where there were actually substance treatment providers that could provide them with the next step. So you'll see those kinds of models developing in Los Angeles, Skid Row, wonderful sobering program there affiliated with USC, the emergency department there. They have bidirectional referral between the hospital, the ER, and the sobering center. Other communities do that type of thing, and that's a model that, you know, we are looking at. And of course, we would, you know, we don't take walk-ins right now, but some programs do that as well. So it depends on what the community, you know, what the design was, the intent at the beginning. But right now, we will occasionally take a referral from a homeless outreach team that, you know, if we see a unique opportunity, we'll take somebody as a one-off. But our program is really designed for law enforcement at this point.
Thank you. And then now this, I think, is for both of the teams who presented today. Folks would like to know, how are you all integrating peers into the work that you're doing? So I'll just open that up for whoever would like to respond to that.
So for Billings, we were actually approached by Rimrock Foundation, our local inpatient service provider, and said they have 2 members of their peer support team that would like to essentially use the Downtown Billings Alliance, where the downtown resource officers are based out of, as their home base for their outreach. And it's essentially turned into a small team between Cody, the officers, and the peer support, and going out and doing outreach with Cody especially. And then coming back to us and asking about different programs we have available, what are this individual's warrant statuses, et cetera. And, you know, it gives a great opportunity for them to not only ride with the officers as well, because they can make a connection that we're not able to make because we're not in recovery, you know. And so it's a great step to use, and we're just happy to have them.
In San Diego, very similar. They're integrated into our outreach teams, also co-responders in our psychiatric emergency response team. So very similar to what Billings is doing.
Yeah, we're fortunate here in San Diego that our county has invested quite a bit in what we call PERT, Psychiatric Emergency Response Team. These are individuals that actually have psychological training and advanced certifications. They actually have the authority in our community to put somebody on an involuntary hold, but they are mental health workers and they are partnered with law enforcement, and we attempt to respond them whenever we have a mental health emergency. We just don't have enough. We've got a lot, but basically we probably could never have enough. But we've had that since the 1990s in our community. And then lastly, when it comes to peer, many of the folks that work at, you know, in our programs have lived experience. So I would say that, you know, there's just nothing like individuals who are in recovery who really get it to be a part of the team. And that, you know, that is probably one of the most important individuals you've got to have on board, whether it's an organization or an individual who starts it out with you. But that's just, you got to have that person, and there are plenty.
Thank you for that. So this question, I'm not sure if the audience member was speaking to a specific program or it's just general. So again, just for whoever would like to respond, so if somebody declines participation in the program, would that result in jail time? Is there a scenario in which that would result in jail time if they don't want to participate in the program?
Yeah, so as far as Billings is concerned, MAP is simply a sentencing option. So an individual is arrested on, right now due to COVID, approximately 20 to 40 active warrants for those quality of life violations. And so when Officer Manser and I, who are the only individuals allowed to arrest on those warrants, take them to jail, they're going to get seen by the judge during their arraignment. And during that time, they can offer treatment through MAP. And if they decline that, they can always choose to plead guilty and just sit out their time, then it's at the discretion of the judge as to how long that sentence will be. And they also have the option of pleading not guilty too, and moving forward with a trial for those crimes as well.
So one portion of that is there has to be in our program something in place if the sentence program is not followed through with, and that is jail time. And so the way our city attorney has framed it is that they're either one being released or furloughed on their sentence to go to treatment. And so we do have a misdemeanor escape charge, and we also have revocation warrants can be issued if someone doesn't follow through because they're being let out of jail to complete these programs. And without that fallback of if you don't complete, you could be held accountable with jail time. We saw the exact scenario when MAP went away in 2014 because of jail beds. We had people sentenced to the MAP program knowing they couldn't go to jail, and so they absconded immediately, almost 100%, and the program came on a pause. And so having that backbone, so to speak, is crucial for the sentence side of it.
When you look in the, if you didn't get a chance to see our first webinar, we present some data from the serial inebriate program, which looked at the duration of sentence and the likelihood that an individual would accept the program. And we have a uniform sentencing structure in San Diego so that on the first encounter, the judge is most likely going to order 30 days in jail versus the treatment program. The next it's 60, then 90, 120, 150, and all the way up to 180 days. And the probability of accepting treatment goes up over 60% when individuals have accomplished 90 to 120 days in jail. So, so there is a consequence. Our program has been referred to as a forced rehabilitation strategy. It's not designed to be anything other than helpful, but many clients, and John took care of everybody in the city of San Diego for 20 years. But the answer is they will tell you it's the worst, best thing that ever happened to me.
But now today, I mean, our goal is jail is absolutely the last resort. I mean, we don't want individuals going to jail at all. That's why we're having officers take people to the sobering center for whatever addiction they have without jail. So our goal here in San Diego really is to have very, very, very few people involved in the criminal justice system at all. That's what we hope. I mean, you know, I hope we can get to that point, but we're definitely headed that way.
So,
Well-
sorry. I was going to say one last piece of that is we have individuals that live on our streets in Billings, and they, and more than a couple, have asked if they can be arrested so they can enter MAP. And every single time we tell them you voluntarily can go, they tell us they know that won't work. They want to be arrested. They want to either want to taken care of. They want to get in front of the judge, and they are asking us, human being, take me to jail so I can get into treatment because I will not do this by myself. And they mean it, and we are working towards that.
It's very interesting. Some individuals really like taking the drug and abuse because they know there's a consequence and they can't hold off without it, but they voluntarily will take an abuse. And I think these are similar strategies that individual people have to deal with their own demons.
They like to be held accountable by something.
Yep.
And with that, we are coming to the end of our event. There's just a couple last items I've got to quickly cover. You should have seen a file transfer box pop up on your screen. So this is for those of you who would like to download the certificate of attendance. You can select the file inside the box. It'll turn dark gray, and just click the download button, and that should start the process to download it directly to your computer. There's also a poll, the last poll of the day, popping up if you would like to put any input regarding additional TA or other areas where you would like information related to what was covered today. Please go ahead and indicate that, and we will be sharing this information with SAMHSA. We also would like to share some information about some upcoming webinars this month and going into June. And information about these, including the registration links, will be provided on the Gaines listserv And if you do not already subscribe to the listserv, here is the address where you can subscribe. And finally, I just wanted to thank once again all of our speakers today, as well as everyone in the audience for attending. If you have any questions or comments, the Gain Center's direct contact information is here on this slide. Please feel free to reach out to us by email or phone at any time. And I hope you all have a great afternoon.
Say bye, Ollie.